Okay, thank you so much, everyone, for joining this webinar, Beyond Borders, Reclaiming Voices in Global STI and HIV Prevention. This webinar serves as an opportunity to share research findings that became inaccessible due to some of the funding and political barriers, including visa denials and canceled grants that really limited some attendance for the STI and HIV 2025 World Congress. I want to thank our co-hosts, including the STI and HIV 2025 World Congress leadership, Mark Stebbin and Joanne Dillon, the International Union Against STIs, and the International Society for Sexually Transmitted Diseases Research. I am also joined today by my co-moderator, Dr. Progress Agbula, and you guys will hear more from him later in this session. We will have 4 incredible presentations today, and bios for each presenter will be available in the chat. If you have any questions, you can always put them in the chat or the Q&A box, and Progress and I will get to them during the appropriate Q&A sessions. This webinar will be recorded, and the recording will be made available shortly on stiwatch.org. But for now, I will turn things over to Joe Tucker.
Thanks so much, Dr. Folkman. It's really a pleasure to be here. And I was just reflecting before, like, I don't think I've seen anything similar to this ever, right? So, like, every conference has um, different variations on people being unable to join the conference. And yet, I feel like having some kind of accountability and sort of reflection on how things went is really important. My remarks will be brief, but first I just wanted to kind of recount what happened with this conference and what happened well and what could happen better next time. Um, and then give some specific suggestions for different groups of people attending conferences. So the STI and HIV World Congress is really, it's an exceptional Congress. And for people who haven't joined it before, I highly encourage you to look at either the next regional or the next world IUSTI meeting or the biannual version of this meeting. The next one of these sort of STI HIV World Congresses will be in India in 2027. Um, and as our team was preparing for this, we had invited about 12 people from low and middle income countries to join the conference in person and take part in a participatory workshop. And we knew that this would be sort of like a steep hill, so we started really early, and we were very compulsive about dotting I's and crossing T's, getting the right letters. And we had our participants submit their all the documentation to the relevant Canadian embassies in their home countries. And and then pretty quickly we started to hear, oh, visa rejected, oh, visa rejected, oh, visa rejected. And it really wasn't a good chunk of people who were full-time researchers that have gone to other international meetings were having their visas to Canada rejected. And it, you don't have to go far back to think about a global conference in Canada where a similar thing happened. The International AIDS Society conference had a lot of missing voices as well. And so I thought, uh-oh, is the same thing going to happen? So we talked to the leadership of the conference. We huddled and made a plan to add some additional documents because this workshop was being supported by the World Health Organization. We got an additional letter of support from Geneva. Um, we sort of went back and did a second round of pushing for the people who had visas rejected. Silence. There was nothing. There was no response. So So then we went back and found Canadian members of parliament who had a history of being interested in health and social justice, and at least one of them very kindly took this up and said, "All right, I'll help to really push on this issue." Some members of our team reached out to journalists to kind of get the word out a little bit more. It ended up being a much longer process than I would have expected. And some of the participants who we had invited were really and I shouldn't say some, like all of them, 100% of them were amazing people. And it was clear, like the letters were really clear on this point. It wasn't like they were missing anything. So then at the end, and gradually after all of this sort of push, we had a few um, people have their rejections reconsidered, a few more, until the day of the conference. 10 out of the 12 people who we invited ended up being able to join the conference in person and participate. Um, it was a long process, much more arduous than I would have thought, totally worth it in the end. And I do feel like a lot of the same structural and systemic factors would have been the same if it were the United States, the United Kingdom. Almost any high income country these days is really, really difficult. And that just, it pisses the hell out of me. Sorry, I hope AVAC doesn't get upset. It's just, it doesn't sit well because I feel like we talk about diversity, equity, inclusion, but as researchers, conferences are like the kryptonite of the whole process. Like you meet people in person, you have dinner with people, and not just people, like funders, people who are really important in the respective field. So it's like an important piece of being a researcher or being part of an STI or an HIV research community. So I think and in terms of like, so what do we do now? So if you're a person who's living in a high income country, and collaborating with LMIC folks, I encourage you to really early on think about these timelines and be an ally. Stick your neck out because there's not going to be someone um, else who's going to stick their neck out and fight for LMIC inclusion. It's really important. And if you're living in a low and middle income country, I would say start the process really early. Be compulsive about all the dotting I's and crossing T's. And also be aware that a lot of these structural issues, um, these are not, it's sort of like a person at a desk doing their job, and they're using the rules that they're instructed to use. And even in sort of these systems, they can generate kind of incredible unfairness. Um, and so for the LMIC, if you're applying to attend a conference like this, um, thinking about contingency plans, thinking about doing all of the legwork super early, I think is quite important. And then finally, if you're organizing a conference, I encourage you to follow the footsteps of AVAC and Dr. Footman, like organize stuff like this. Call it out. This is not a secret. This should not be something that's like on the margins. No, no, no. Like this is a global conference. So like really stepping it up so that the organizers and the intent, not just the intent, but the action of the conference follows along with a truly global kind of remit. I mean, I think for me, it's like a really important point. Um, Conference organizers, the online parts and the hybrid aspects of conferences are important and useful, and I think that's a nice adjunct. And but at the same time, like figuring out visa rejections, really pushing on them to get them reversed is an important part of what it is to organize a conference in 2025. Um, and then just finally, I'd like to thank again Dr. Footman for her leadership and thoughtfulness in organizing this. I hope we can do this again for other conferences. I think this is an important kind of ritual that has been started, and if we reflect a little bit more on it, I think the next conference will be easier. There'll be a greater chance that we'll be able to include more people from not just from LMICs, people with disabilities, people with caregiving needs. There's a whole bunch of intersectional issues that prevent some from joining in-person conferences. So really digging in deeper and thinking about this is an important issue. So I am happy to, I'll be around. I'm going to watch with great interest the rest of this. I will be around for the Q&A at the end. And I'll turn things back over to Dr. Footman.
Thank you so much, Joe, for those remarks. And now we are going to move into our formal presentations, the first being with Dr. Linka Vostril. And apologies to everyone, I am terrible at pronouncing names, and it is something that I'm working on. So I will continue to butcher everyone's name throughout this, but it does not take away from your important work. So over to you, Linka.
Thanks so much, Alison. I'm just going to share my screen. How is that? Are we good?
It's perfect.
Great. I'd just like to start by seconding, I think, a lot of Joe's remarks. And I'm really here as someone who was privileged to go to Montreal and present this work. And I think saw this as an opportunity to extend the sharing process on a global scale. So I'm really grateful that Dr. Footman was able to organise for me to join this seminar. I'm terribly sorry that I won't be here for the Q&A at the end, mostly because it's nearly midnight where I am in Australia. But I do ask that anyone who wants to contact me about my presentation or findings or wants to learn more, please do reach out to me with my email on the screen there. Or you can contact Alison, and I'm very happy to share my email. So my presentation at the conference was really an extension of a large male partner treatment trial for bacterial vaginosis that was published earlier this year. And so I'd just like to acknowledge my co-authors before I begin. And I'd also like to acknowledge the traditional owners of the lands on which the studies that I'm talking about took place. These are the Bunurong and Wurundjeri clans of the Kulin Nation in what we call Victoria or southern part of Australia. And here are my disclosure and my disclaimer. When I'm referring to women and men in this presentation, I'm including people with a vagina or a penis respectively. And I acknowledge that not all people may use these terms to describe their gender. So for those who aren't as au fait with bacterial vaginosis, it is the most common vaginal dysbiosis affecting reproductive aged women globally. And it's associated with substantial obstetric and gynecologic sequelae, as well as negative impacts on quality of life and relationships. While treatment is with broad-spectrum antibiotics, over 50% experience recurrent BV within 6 months of treatment. And this actually rises to 60 to 80% among women who have an ongoing regular sexual partner. So we hypothesised that reinfection was responsible for a significant proportion of repeat BV positivity after treatment. And we conducted a randomised controlled trial of concurrent male and female treatment So men and women received partner treatment at the same time versus the global standard of care, which is female-only treatment. And what we found in our RCT was that partner treatment had a dramatic effect in reducing the number of women with repeat BV positivity within 3 months of treatment. So you can see this summarized in this plot here. We had a hazard ratio of 0.37. And this really confirmed that sexual transmission is a significant driver of BV recurrence. But there was a smaller group of women who had repeat BV diagnosis in the intervention group, with about 35% recurring within 12 weeks. And we knew that reinfection wouldn't really be the only driver of having repeat BV diagnosis following treatment. We'd previously hypothesized that there were two main pathways responsible for driving repeat BV: reinfection and also post-treatment persistence of BV-associated bacteria or biofilm. So we really want to understand the contribution of both of these pathways to repeat BV. And we also wanted to know more what drove repeat BV after the intervention for that smaller group of women. We think that reinfection was not prevented in all of the women. We know that poor adherence was linked to treatment failure, with the lowest rates of repeat BV among women whose male reported taking 100% of their combination therapy. And we also know that, or think that treatment may not eradicate male carriage of BV bacteria, and this may contribute to reinfection. It's also possible that there was unreported intervals of sex during treatment or new partners that were concurrent partners that may cause reinfection or a new infection. But for others, we hypothesized that persistent infection may be driving treatment failure. So we conducted a study among a cohort of couples receiving concurrent female and male partner treatment for BV, with the objective to determine the factors associated with repeat BV at 4 weeks. Our study endpoint was a BV diagnosis within 4 weeks of concurrent partner treatment, and we used both clinical and microbiological endpoints to describe BV. So for this analysis, we actually pulled 3 different cohorts of couples that we have recruited over a number of studies. So the first were the 2 pilots we ran in the lead up to the RCT. And for this, all couples received concurrent partner treatment. Just noting here that men are treated with both oral metronidazole and topical clindamycin cream. I'll go into this in a moment. Whereas female received first-line care. We then also included the intervention group of our RCT, and couples were randomized to concurrent treatment or standard of care, but we only included that partner treatment group. And finally, after we finished recruiting to the study and before the publication, we ran an open label extension study, and this continued to enroll or provide access to couples with partner treatment while we waited for the publication to come out. So we enrolled a further 70 couples to that. So to be eligible for partner treatment, women had to be over 18 years of age and have symptomatic BV, and also report a male partner for the 8 weeks leading up to enrolment with no other concurrent partners. And we merely emphasised that this intervention was not going to work if you had other concurrent partners. So we also confirmed that there was no concurrent partners with the male partner independently. We also checked that the male partner didn't have any contraindications to the 2 antibiotics that were being used for the intervention. And for the pooled analysis, women were eligible if they returned for a week 4 study visit or returned a vaginal smear via the post for Nugent scoring. So for those of you who are not familiar with Nugent scoring, this is a score from 0 to 10 that is applied looking at the bacterial morphotypes under a microscope. So here's an example in the first panel of a cell coated in healthy optimal lactobacillus species. So this is a low Nugent score slide. And the second one is an example of a slide of a clue cell that's coated in mixed anaerobic bacteria, predominantly representing Gardnerella in that slide. So for treatment for all of our studies, women, as I mentioned, receive first-line treatment. So in our setting, that's oral metronidazole for 100 milligrams twice a day for 7 days. There was a minority given intravaginal clindamycin cream as an alternative if they'd reported a previous reaction to oral metronidazole. And for men, they received combination therapy. So in trials leading up to our own trial, they had only really focused on using oral medication, but because of the growing body of evidence that the BV-associated bacteria were located in the urethra of men as well as on the penile skin, we also used topical clindamycin cream as our second antibiotic for men. And men were instructed to pull back their foreskin if they were uncircumcised to apply the cream. So our measurements were BV at week 4, as I mentioned. We also looked at adherence and behavioural and sexual practices at each time point of follow-up. The analyses included a cumulative rates of repeat BV per person year, as well as Cox regression to generate hazard ratios for time to event of key risk factors. So just briefly looking at our study population, in our 3 cohorts, they were very similar overall. Some main things to point out was that a third of our population have a IUD in situ, mainly reflecting use of a levonorgestrel IUD or intrauterine device. In our setting, about 20% of men are circumcised, and that reflects the number reflected the population in Australia. We also have a high burden of BV, repeat BV, among the women who enroll in our studies, with 80% reporting a past history. So we're really following a cohort of women with a high burden of risk factors for bacterial vaginosis. And just of note, we still saw an effect in the main trial despite this high burden of risk factors, which was always promising. So quickly, just looking at the pooled rates of repeat BV by week 4, when we look at our cohorts, they're all sitting pretty similarly, with the extension trial having a slightly higher recurrence rate, but the pooled recurrence rate was 2 per person year. And just I've popped on the control group was 5.4 per person year in the main RCT. You can see this also plotted on the graph. And just of note, the extension study had a far higher loss to follow-up rate. And we believe this is because people were aware of the findings. Clinicians knew at our service that we had shown a benefit of partner treatment. So couples are really using the trial to access partner treatment and were less likely to attend for that follow-up visit if their symptoms had cleared. So that's our reasoning behind why we think we had a slightly elevated recurrence rate. Just touching on adherence, overall, women are really good at taking all of their medication, and you can understand why. They're symptomatic, they've got BV, they want to clear their infection. And male adherence was really mixed. While about 85% took all their metronidazole doses, only 60% applied all their doses of clindamycin cream. And we've looked a little bit further into this and seen that men do prefer the oral metronidazole tablets. You can understand that it's more practical to take a tablet rather than to apply cream topically. But they really do report finding both easy to use and would do the take treatment again if they were asked to by their partner or they had to. So I think that we've delved into that motivations for taking partner treatment a bit more and found that. So this is a really busy table, but really the take home here is that the number one or the main reason why women experienced repeat BV in this cohort was that what we found was that at day 8, so this is the day after treatment is finished, before most couples resume sex, they have an elevated Nugent score. So this is represented by a score of 4 to 6, which is intermediate BV, or 7 to 10, which reflects BV. So these women are not really clearing their BV at all before they're resuming sex with their partner. And that might be explaining why they're having recurrence. We also saw elevated hazard ratios for all of the key risk factors. They weren't significant, likely due to the smaller groups in these sub-analyses. But we did run a multivariable Cox regression, adjusting for some of the key risk factors. And this really confirmed that an elevated Nugent score the day after treatment was associated with a 4 to 5-fold increased risk of repeat BV at week 4. And this was also what we found was that IUD use was associated with a 2-fold increased risk of BV. And so we wanted to delve into this a little bit further and see how these two factors were related. So I stratified IUD use by the presence of an elevated Nugent score at day 8. And what this really showed was that the lowest recurrence or repeat BV rates were seen amongst women without an IUD who had cleared their infection with their first-line antibiotics. And the highest rates of repeat BV were seen in women who had an IUD and also failed to clear their BV-associated bacteria at day 8. So this indicates to us that treatment failure is occurring in some women. So in this pooled study of male partner treatment, the overall recurrence rate was around 2 per person year, and failure to achieve an optimal vaginal microbiome was associated with an elevated Nugent score immediately after treatment. So why might this be happening? We think that there is a subgroup of women who may not be responding to first-line therapy. And this may be because they've got persistent BV-associated bacteria or a persistent BV-associated biofilm. It may be because they're failing to recolonize their vaginal microbiome with optimal lactobacillus species after treatment. And there could be other host genetic factors for this. Another key risk factor was intrauterine device use. These IUD users are overrepresented in our population compared to the Australian population, with about 4 times higher use. And although these mainly represented hormonal IUD users, and we know that copper IUDs are associated with increased risk of BV, the message really is here that we don't know exactly what the role of the IUD is, but the IUD strings may provide a nidus for a BV-associated biofilm to adhere to. So these are the focuses of our ongoing research. So just to summarize, we've really shown that there are two key pathways to drive repeat BV positive. Recurrence, which we associate with reinfection from BV-associated bacteria, and we have mitigated a large proportion of this by providing male partner treatment with this combination treatment strategy. And we know that improved adherence could further mitigate or prevent reinfection. And the other pathway is persistence. And yes, IUDs may be playing a role in this, but there are other factors that may be underlying persistence. And underlying both of these pathways are some other interrelated mechanisms, such as failure to recolonize with optimal lactobacilli and other host genetics or altered immune pathways. So just to finish, I just wanted to put up this figure that comes from Nature Reviews on BV. So if you want to learn more about BV, I recommend finding our review from earlier this year, because it really is the A to Z of BV. We believe that there are multifaceted approaches that are needed to eradicate BV-associated bacteria for biofilm. We've shown that partner treatment can be one of the key pathways to prevent sexual transmission of BV-associated bacteria. We know that we need to optimize adherence. Could be that some men may benefit from a longer duration therapy. And we also recognize that we haven't touched on female partner treatment here, but that's part of our ongoing research. Some women may also benefit from longer duration therapy to further eradicate BV-associated bacteria. And we also recognise that agents to disrupt biofilm are lacking from our toolbox. We are looking further into the role of the IUD. We know that hormonal contraception in general is preventative against BV, but we're not sure what the role of a hormonal IUD is. So we're doing further studies to look at this, and it could be that for some women with ongoing persistent troublesome BV and IUD removal and retreatment is the way to go. And finally, there are other adjunctive therapies that may be needed to promote an optimal vaginal microbiome, including lactic acid and live biotherapeutics. So I'd just like to finish by thanking the enormous team behind this work. The head of our group is Professor Katrina Bradshaw. We're based at the Melbourne Sexual Health Centre in Melbourne, Victoria, as I mentioned, but we have other collaborators around Australia. So I'd just like to end on that.
Thank you so much for a really fabulous presentation. And I think a question for you that I know we receive a lot and I hear a lot, and I'm wondering if you can add your thoughts to this is BV isn't always considered an STI. And so why is that, especially when thinking about some of the work you presented and the relationship with sexual transmission and treatment of sexual partners?
Yeah, it's a really good point, and I've answered a similar question many times this year since our paper came out. Because there was a lot of media hype initially after the paper came out, because I think that sexual transmission resonated with a lot of individual women out there and also clinicians who treat BV. I'm not a clinician myself, I'm an epidemiologist. So I looked at many studies over time and saw that BV was behaving like an STI in a number of settings. It's associated with a new partner. It's associated with lack of condom use. It's associated with it's also on the flip side, people have ongoing symptoms if they have the same partner, which, we weren't treating for a long time. There was also a big body of work that's emerging with the generation of high throughput sequencing, which shows that male partners are carrying these organisms associated with BV in the urethra and on the penile skin, as I mentioned, and that carriage is associated with an increased risk of catching BV for the first time for women. But despite all of that emerging evidence that's been generated over the last 20 years, there were trials that looked at partner treatment and they failed. And I think they failed for a number of reasons. There were some that were unfortunately lacked power, statistical power. They didn't report on adherence. We showed, and so did another study showed that adherence is really important. So I think, and for the first time, we added the topical cream to partner treatment. We also really focus on closed couple relationships, which I know is not necessarily convenient or practical in a lot of settings. And also for women who have a casual partner, that's a sort of frustrating thing to hear. But I think what we now talk about BV as being sexually transmissible, some people might call it an STI, but we think that being really inclusive in our language is really important because men traditionally don't have symptoms. It's really hard to, or it's really important to not stigmatize people with BV and make them feel like they've caught something new when perhaps they've had it before. So we talk about, as I mentioned, BV being sexually transmissible, and like any STI, if you don't treat the partner, there's the risk that you're going to keep having the same ongoing symptoms. And that's where our intervention actually reduced BV recurrence significantly for women who were really set up to fail. They had a lot of other risk factors. So I think it would work even better in people who are in new relationships, who are just starting a new sexual relationship and they've got their first case of BV, and maybe in those women, you can have the conversation that we don't want a BV biofilm to form. It's really important to, if possible, to talk to your partner and get them treated too. So I hope I've kind of answered your question in a roundabout way. I think I threw in a few extra learnings from this year. I don't know why that picture keeps popping up behind my shoulder. There's no other people in here. But yeah, I think that it's a really important question, and we've got Australian STI guidelines now recommending partner treatment. And there was a it recently came out in the American GYN guidelines as well. We know that guidelines are often behind because they wait till they gather enough evidence to make changes, and that's completely rational. And we know that lots of guidelines are impacted by funding, or committees are impacted by funding currently. But yeah, we've seen that there have been practices who have adopted our work. We have a website which has all the information that can be accessed anywhere in the world. It's called BV in Focus. We have a New York City clinics who have translated our instructions for men into 13 different languages, and they're happy to share those instructions. So I think the main point now for us is to try and to understand implementation and how that can work, to listen to different diverse settings and what we can do to support them, and also recognise that this is a paradigm shift. The language shift might take a while to catch up. So we're very open to having these discussions. Thanks.
Well, thank you so much, Linka, for a fabulous presentation and for answering that question. We really appreciate your time today, and I hope that the rest of your night goes well. And with this, we will move to our next presentation, which is Lawrence. So Lawrence, if you could share your screen and begin, we would appreciate it. Lawrence, are you able to share your screen right now?
Hello everyone. Thank you so much. My name is Lawrence Juma. I'm glad to be in this conference to share the work that we did with other co-authors, and also on behalf of the collaborators, Cambridge, STI and University of Washington. Yeah, then so I'll share about the EPT or paratherapy uptake and STI clearance rates among cisgender women who are in doxycycline post-exposure prophylaxis study in Kenya. So EPT, I think, is well known by most of us. So on the background, EPT, this is STI infection, or following treatment without requirement of clinical evaluation for the partners. So we do EPT or just reach the partner, or for the participant, or for the client who has STI, either chlamydia or gonorrhea. So use of EPT has been rare in sub-Saharan Africa due to lack of ecological testing, which is often unavailable. And therefore, we mostly use syndromic approach of treatment. So partner engagement is very important in regards to HIV or self-testing, and also linkage into care. This is very important to improve PrEP and also ART uptake with low rate of social harm. Then the arrange also can be reinforced when the partner is included, or disclosure done, and support offered by the partner. This one can also boost the adherence. Then that's why we had a focus on partner therapy. So in this study, we just understand the factors that were linked with EPT uptake and the clearance of STIs in this study. It is very critical to optimize intervention strategies. So why focus on the STIs? The STIs are on the increase, or with more than double increase in the last decade, and there is a burden of STI among cisgender women. STIs, they can increase the risk for HIV acquisition when not well managed. Then it can also lead to pelvic diseases, which are also very
It looks like we lost Lawrence for a little bit, and while we wait for him to rejoin, oh, here Lawrence comes back. Hi, Lawrence. We can't see your presentation anymore.
Can you hear me?
Yes, we can hear you.
Oh, sorry.
Would it be helpful for me to share your slides? Hey, Lawrence, would it be helpful for me to share your slides?
Sorry with my net. Sorry. Sorry. Can you hear me now?
Yes, we can hear you.
Oh, sorry for that. Sorry. Yeah. So STIs. There's much focus on the STIs. It is a burden of a lot of sequel, and therefore there's much focus just to protect the cisgender women due to its increased HIV risk acquisition, or also can lead to pelvic diseases, infertility, and pregnancy complications. Wow. Can you see my slide?
Yes, we can see your slides.
Okay. Okay, so this study, we had an objective with just investigate the factors that are linked with the EPT uptake and clearance of STIs. Chlamydia and gonorrhea is the focus here among young women in the doxypep trial. So the design of the study is an analysis from the Kenya study, where we enroll women, cisgender women, 18 to 30 years of age, who are taking HIV PrEP, and those who had also had positive results for the STIs. So we had 140 women, and we took 209 visits. So we also did testing for STIs, gonorrhea, chlamydia, every 3 months through a 1 year follow-up period. And those with positive STIs received treatment as required by the guideline. And also we did a test of cure tests for participants with positive STIs between 2 weeks to 4 weeks after treatment. Analysis, we did a chi-square test exam between EPT and participants, demographic characteristics. We also did generalized estimating equation, GE model, which compared visit level EPT uptake by participant characteristics and test of cure results. So on the results, this was what we came up with in our analysis. Yeah, you can see from your end, there was some kind of association between there was high uptake. So there was high uptake of EPT among women, where most of the women were able to accept that they could have additional dosage for their partners, that they may be able to treat their partners as well. So there was high uptake. Then the women who earned their income, or 61.9%, were more likely to accept EPT compared to women who did not earn income. Then women who reported personal sex at any time during the follow-up period, or this around 54.3%, were more likely to accept EPT compared to women who do not report that. Then having a primary sex partner within the past 3 months was also having some association with the study visit where EPT uptake occurred. So this is, Then participant study visits when with partner or violence in the prior 3 months was also linked with the decreased EPT uptake. So there were some plans who are afraid, or they were afraid of partner violence. Yeah, so this one was also having an impact of the EPT uptake for those who had STIs. They was that fear to approach their partners. Then in a multivariate analysis, partner violence remained negatively associated with the EPT uptake. Then in terms of STI clearance, remember I said we did test of cure within 14 days, 28 days after receiving treatment. We had some class who had positive STI, with positive STI then after receiving EPT, and I think I've lost my slide. Can you see my slide? Okay, thank you. Yeah, so there are participants who had positive STIs. Among participants with positive test results, they tended towards more accepted EPT, 83.3%, compared to those who declined EPT at 16.7%. Then among participants with a negative test of cure results, more accepted EPT compared to those who declined. So what we can take home from this discussion, or lack of impact on clearance of STIs, despite high uptake for EPT, there was still there was a lack of impact on STI clearance. Then we had also, this study was limited by lack of partner behavior data. The sample size that we had was low. Then we considered the opportunities to actively engage partners to optimize EPT without offsetting the advantages, and also equitable and cost-efficient approach to STI management. Then we also, our study indicates that participants were able to self-identify the risk for intimate partner violence and therefore declined the EPT uptake for fear of violence. Then we also had a limitation on lack of data on if or EPT was offered and accepted by the partner. So we focused mainly on the participant, on the client, but we don't have data to show that indeed or the partner was able to take the EPT or medication. In conclusion, despite high rates of EPT uptake, especially among those with their own income and engaging international sex work, EPT was not associated with the clearance of STIs at the test of Q1. Yeah, thank you so much, everyone, for your time. Acknowledge study participants, for the study PI, the study staff, the study funder, and also everyone, and also the collaborators, and also the co-authors for this work. Yeah, in the image of the study team that we want to work with that study. Thank you so much. And apologies for my internet, sorry.
No worries, Lawrence. Thank you so much for a fabulous presentation. Just a reminder to all of our attendees, if you have questions for our presenters, please put them in the chat or the Q&A box, and we will be able to answer them once all of the presentations are done. So again, thank you, Lawrence. And with that, we are going to move to our next presenter, Caleb Anulobi, which, sorry for the mispronunciation. And I will provide Caleb's bio in the chat. So thank you so much, Caleb, and on to you.
Okay. Yeah, thank you for the opportunity. Okay. So my name is Caleb Anulobi, and I'll be making a presentation on a continuous quality improvement initiative, which we did on improving pediatric and adolescent viral load suppression rates at the Ekiti State University Teaching Hospital in Nigeria. Okay, so there are no conflicts to disclose. Okay, so what are the issues? So we know that viral load suppression is critical to the management of patients living with HIV, especially the pediatric and adolescent subpopulation. And at the Ekiti State University Teaching Hospital, we monitor our viral load suppression rate over a period of time. So between November to February 2024, when the team met, we reviewed and saw that there's a poor suppression rate over the quarter, ranging from 82 to 85%. And this leads to interruptions in treatment, on suppression, and death. So we applied the fishbone analysis, where we categorize the root causes into factors that are related to the patients, factors that are related to the caregivers, the factors related to the household, and then institution or the process. So when we looked at it, we saw that for the patients, we observed low health literacy because, we know that at this age and in the population as a whole, the level of health literacy is not optimal. We also discovered scheduling difficulties because these are school-age children where we know the typical clinics run from possibly 9 a.m. to 4 p.m. and these are times that children need to be in school, and coming for their clinics is usually a problem. Then we also discovered transportation problems to the facilities. Coming from their homes to the facilities can be a challenge. Now, the part of the caregivers, we noticed low caregiver health literacy, religious, socio-economic beliefs, where over a period of time, some people can, deny their status or otherwise. Then low socioeconomic status. On the part of the household, we discover disclosure problems where children, especially children up to age or adolescents, start asking questions. They want to know why they are taking the ARVs, the antiretroviral therapy. So, and in the case where they don't know, we always have difficulties with them taking their medications. Then we had frequent changing of caregivers, where for some of the patients, the mother might have been deceased, and they are living with caregivers, probably grandparents or other family relatives who do not really understand the importance of their ARVs. Then we had problems with on the institution, we had problems with inefficient tracking system and human resource gap, the typical brain drain in the Nigeria healthcare system. So for this, we did both a quantitative and a qualitative analysis, where on the part of the quantitative analysis, we used data from the our electronic medical records, where we looked at patients that are supposed to come for refills, patients that come for refills, those that eventually had their viral load suppressed. Then on the part of the qualitative analysis, we had the focus group discussion and interviews of the healthcare workers themselves, the pediatric and adolescents, patients, and their caregivers. So at the end of the day, we analyzed our data using MSSL. Then we also used the PDSA, that's the plan to study at, to apply cross-cutting interventions to the root cause analysis, to the challenges we discovered. Now our aim was to improve the suppression from 85% to 90% over a 6 months gap, which was from February to September 2024. So looking at all these, we applied certain innovations, 5 of them specifically. The first one was client-focused adherence counseling and clinical review, where we discovered that sometimes where you're trying to ensure unsuppression in the suppression in the unsuppressed group, we found suppressed getting unsuppressed. And what we did was, for each patient that come for review, we center our care according to the need of the patient. So it wasn't generic counseling this time around, it was client focused. Then the second was, we had parents or caregivers participation in a caregivers forum, where we had meetings that were organized every quarter, where we had caregivers of these patients come. It served an avenue for capacity building, for knowledge sharing, and motivation across the parents. Then there was also the training of adherence healthcare workers, and this was monitored weekly. We also applied the 30-day adherence calendar, which had specific duties for every patient, at 30 days on enrollment to treatment, where we used to send reminders and days how they're supposed to take their medications. Then the last was a case conferencing model, where we discovered that apart from the medical factors, the immune status, the HIV, there are also the social determinants of health that impact so much on the healthcare, such as housing, where they grow up, where they live, the occupation of their relatives. So for this, we also reviewed it through a multidisciplinary approach, where for each of the patients we applied solutions to what the problems are. Okay, so the lessons learned, what did we learn? So we learned that the case conferencing model was most effective, because we had patients that their means of livelihood, their occupation wasn't really optimal to cater for the family. So we had some form of empowerment for them. People that had skills, we had to, recommend and establish good businesses for them. People that do not have skills, we also encourage to learn one skill or the other. And we also observed the second lesson is that 90% of our patients that passed through the model had their viral load suppressed at the end of 6 months period. Then the last was that the collaboration between the orphan and vulnerable, children's teams. We had a team that is in charge of orphan and vulnerable children, then the social workers, the clinical team, mental health specialists. This promotes service integration where we attend to patients, as a whole, where we apply holistic care to patients, where we also look at other factors that may be affecting their treatment other than just taking their antiretrovirals. Okay. Then the next steps, what was the next step for us? At the end, we established that for each of our patients that is enrolled into care, from the point of enrollment into care, we apply this case conferencing model for them, where we don't have to wait till 6 months when we're taking when we're checking for viral load suppression. We discover that they are unsuppressed. At the beginning, the first 3 months, we want to ensure that their cares are tailored to them. We want to ensure that if the other social determinants of health that we can who can cater for will do that. Then also next step was to develop a manuscript, where we would share our knowledge with the scientific for what we're doing, and yearly CQI exercise. So our take-home points, one is that the multidisciplinary approach through service integration, that enhances viral load suppression, where patients are looked as a whole component and not just looking at their viral load suppression alone. Then the second take-home point is that case conferencing model that addresses the social determinants of health improves pediatric and viral load suppression rates. Thank you.
Thank you so much, Caleb, for another amazing presentation. And we will have an opportunity to ask Caleb additional questions during the Q&A session. But for now, we are going to move to our next speaker, Favor Abeen, and Favor's bio will be in the chat. So Favor, are you ready?
Yes, I'm ready. Good morning. Okay. I am Favor Ebine, not Favor Ebine, but I'll go on. Okay, my topic is perception, preferences, and feasibility of HPV DNA testing versus pap smear for cervical cancer screening among health professionals in Southwest Nigeria, a cross-sectional study. And this is for the conference, and this is a privilege to be presenting at this global conference themed Beyond Borders, Reclaiming Voices in Global STI and HIV Prevention. I want to confirm you can hear me and you can see my screen.
Yep,
Yes, we can
good.
hear you.
Thank you very much. So these are my co-authors and institution affiliations. And this is my acknowledgement to my team mentor. This is my outline. So as a way of introduction, cervical cancer remains a public health issue in low and middle income countries, despite the availability of effective screening methods like pap smear and human papillomavirus DNA testing. And we all know, especially in this part of the world, Africa, there is a high rise of cervical cancer, and high incidence and mortality persists due to limited screening access, low awareness, weak healthcare systems, and poor follow-up for abnormal results. Additional barriers also include sociocultural factors, absence of national screening programs, and low human papillomavirus, that's HPV vaccination uptake. Also, while pap smear has reduced cervical cancer rates, they have limitations in their sensitivity and follow-up, which is one of the reasons why HPV DNA testing is more utilized or is more advised. So HPV DNA testing is more sensitive, allows for longer intervals between screenings, but faces cost and logistical challenges in low resource settings. Without expanding HPV DNA testing and improving follow-up care, Nigerians may miss the the WHO target for cervical cancer elimination. This study will generate evidence to inform national strategies to improve early detection, reduce late-stage presentation, and also ultimately lower the cervical cancer burden in Nigeria. What is the main objective of this research paper or research study? To evaluate the perception, the preferences, and feasibility of human papillomavirus DNA testing compared to Pap smear, papillomavirus smear, for cervical cancer screening among health professionals in Nigeria. And what methods were used? We used a cross-sectional survey among 100 health professionals in Southwest Nigeria using a structured questionnaire, and data on social demographics, screening knowledge, perceptions, feasibility ratings, barriers, and preferences were analyzed descriptively with chi-square tests for associations between the preferences and the demographics. This is a broader explanation of the method used. We used health facilities in Southwest Nigeria. It included primary, secondary, tertiary institutions, which included government and private sectors, including NGOs as well. And the population included licensed healthcare professionals like doctors, nurses, midwives, lab scientists, community health officers, community health environment workers, and program managers. Then the inclusion criteria was, community health extension workers. The inclusion criteria was those who have worked for greater than 6 months and they give appropriate consent. And the exclusion criteria are the interns, the trainees, unavailable staff, and those that didn't give a consent. A broad sample size was used, but 100 participants, it was narrowed down to 100 participants. And the sampling technique was convenience and proportionate sampling across the facilities. And the tools used were structured self-administered questionnaires, which cover the demographics, the perception, the preference, visibility, and challenges. And the analysis was done using descriptive stats and chi-square with a P of greater than 0.05 significance. So from the result, or from the, after the research study was done, the results gotten were the mean respondent age was 38 plus or minus 38.5 plus or minus 8.4 years, of which 66% were female. Professional groups included doctors of 34%, nurses of 26%, medical lab scientists of 25%, and they were in support of replacing Pap smear with HPV DNA, that's with a population of 61%. 19% were unsure and 20% opposed the replacement. Feasibility scores, which from the Likert scale was lower equated to stronger agreement, were nationwide scale up, government funding, healthcare workers training, HPV DNA sampling in rural areas, integration with maternal health programs. And the main barriers that were noted were inadequate laboratory infrastructure, limited staff training, patient reluctance, supply chain issues, and delayed results. From the results deducted, preference was not significantly associated with gender or profession. Now the discussion afterwards, majority, which is 61%, supported replacing Pap smear with HPV DNA testing. And this shows, or this inferred, a growing professional confidence in the sensitivity of HPV DNA testing. And secondly, high feasibility ratings for government funding, healthcare workers training, and integration with maternal health programs indicated that there was a readiness if systemic support is provided. HPV DNA sampling viewed as feasible implied that it could improve the uptake, especially in rural communities. And the main barriers noted were laboratory infrastructure, staff training, patient reluctance, and supply chain issues. Preferences were not influenced by gender or profession, implied that there was a generally uniform perception across health professionals. Overall, professionals recognized HPV DNA testing as superior, but adoption hinges on addressing structural and resource-related challenges. And in conclusion, there is a strong support for transitioning to HPV DNA testing among health professionals in Southwest Nigeria. Cost, infrastructure gaps, and inadequate training remain the key barriers to adoption. Government investment, improved lab systems, and training programs are critical for this to happen. And HPV DNA self-sampling and integration into maternal health services can also accelerate the uptake. Aligning professional preferences with systemic reforms is essential to achieving sustainable cervical cancer prevention in Nigeria. What are my recommendations? Government funding subsidies government funding subsidies to reduce the cost of HPV DNA testing is one. The laboratory infrastructure should be strengthened to support nationwide scale-up. There should be a comprehensive training program for healthcare workers on HPV testing and self-sampling. There should be a promotion of HPV self-sampling to improve the uptake, especially in rural and hard-to-reach areas. And there should be an integration of HPV DNA testing into existing maternal and reproductive health programs for a wider reach. There should be a strengthening of the supply chain systems to prevent stockouts and delays. And finally, awareness campaigns to address patients' reluctance and misconceptions should be carried out. These are my references, my selected references. Thank you.
Thank you so much, Favor, for a fabulous presentation. With this, we will now move into our global Q&A session with all of our presenters. And so I will hand things over to Progress to get us started on our questions.
Okay, thanks so much, Alison, for the introduction. And to our panelists, it was a beautiful presentation all through. From the first speaker to the last speaker. Thank you so much for your time and the insightful presentation. So my first question goes to the first speaker, Dr. Lenka. Looking at bacterial vaginosis itself is an area that is understudied when it comes to STI generally. So my question is about how your findings can influence clinical guidelines or community-based interventions for recurrent bacterial vaginosis management. Just talk about like how your findings can influence clinical guidelines or community-based interventions.
So Progress, Linka did have to step off of the webinar, and so she's not here to answer that question. And I do know from her presentation, she had mentioned updated guidelines for BV treatment and some additional resources so for those who are still here in the webinar, we can definitely share some of those resources with you and make sure that they are available post-webinar.
Oh, thank you for that, Alison. For Dr. Lawrence, thanks so much for your insightful presentation. My question is, what are the key factors that influenced women's decision to accept or decline the expedited partner therapy? I know you mentioned a couple of factors in your presentation. Could you just emphasize on one or two key factors that influence their decision to accept or decline the expedited partner therapy?
Yeah, thank you so much for that question. As I outlined, there was high uptake for EPT or from the participants that we engaged. So participants were the primary partners. Yeah, they were really able to accept EPT because they know about their partner. Then also there are participants who really understood their risks. Yeah, they understood their risks, and therefore when they were talked about EPT, they were able to make a decision on that line. and able to take EPT. Then there were women who had the financial autonomy, right? Yeah, they are much empowered financially, or they were able to take that decision or to their partner and without fear. Yeah, thank you.
Thank you for that, Lawrence. And lastly, to Dr. Caleb, using the case conferencing model, I find it very interesting. It's something that I personally will read more about. My question is that were there key differences in using this approach between newly diagnosed and probably like long-term clients? Were there key differences in the outcomes when you use this unique approach, case conferencing model?
All right. Thank you for the question. Okay. So there were key differences, basically in the outcome because for the naive clients, that's the new clients, when we applied this model, we found out that they achieved suppression earlier because by 6 months on AROTs, we expect them to have suppression, right? But for the new clients, we achieved suppression earlier, which at the end of the day reduced mortality, which for the older clients or for the previous clients, where we had lots of unsuppression before applying this model, we found out that some of them risk resistance because with increase with unsuppression, you can be mutation in the virus. So yes, there were differences. Thank you.
All right, thank you, Dr. Caleb. Over to you,
Perfect.
Aisha.
So Favor, I was wondering when looking at HPV self-sampling, were there preferences for the location of self-sampling occurring? So, for example, did participants in your study prefer to collect their samples in a clinic or at their home? Did location at all come up?
Thank you for your question. Okay, so yeah, there was a preference among those that were in rural communities because the distance between the community and the health facility was quite something, and they were more willing to accept self-sampling, and it was going to be an encouragement for them to seek care if there was going to be anything of concern after adopting that method for their screening. Thank you.
And for all of our presenters today, there have been global funding disruptions for STIs and HIV. And so I'm wondering how you guys are seeing these funding disruptions maybe impacting the work that you do. So, Caleb, I'll start with you and really asking how funding disruptions might be impacting HIV treatment in your setting and if there are concerns about how this could impact viral load suppression.
All right. Thank you. There's a beautiful question, right? Okay. Um, Yes, the cutoff of funding has affected a whole lot, from the level of care provided to patients, to the commodities, the antiretroviral drugs, the necessary investigations that were being supported, and to and even to the manpower. Right. In on the onset of the cutoff of the funding, a lot of manpower where there was cut down on manpower, yes, which affected the level of care that the patients receive. Then we also discovered that there were some services that were being, forms of incentives to keep patients going and all those things, he has reduced. So at this point, basically, we provide the necessary interventions, which is the ARVs, the monitoring of the viral loads, right? However, irrespective of the funding, the government of Nigeria has been trying to cushion the effects. For instance, I know for my state, I know the Minister of Health ensured that most or even all of them have been enrolled into the healthcare insurance, the state insurance, so which helps in a whole lot. They often, if they don't pay anything because they are enrolled into the package where they don't have to pay anything at all, right? So that's what is being done to cushion the effect. But I know that of course a lot more needs to be done, which I think over time the will wake up to those responsibilities. Thank you.
And Lawrence, for you, the same question and thinking about some of these funding disruptions and how they might be impacting EPT and specifically access to treatments. What are some of your thoughts around that, Lawrence?
Hello. Can you hear me?
Yes, we can.
Oh, okay, sorry. Yeah, so you were asking about I missed the question, sorry.
Yeah, so just thinking about funding disruptions and how this might be impacting EPT and access to different treatments and kind of your thoughts or your observations on this.
Okay, thank you so much. Yeah, so with the funding disruption, I know this has a very big impact in terms of STI management and treatment in regards to testing. Yeah, so we rely on some support in terms of the kits for testing, and therefore it is a bit difficult to make a diagnosis. Yeah, that may help us to offer EPT. So we end up doing syndromic approach of treatment without etiological approach at some point. Yeah, that one is also a big impact. Then also in terms of supplies, also or maybe on drugs, or where some or NGOs they offer treatment free of charge. At some point, clients will have to maybe chip in from their pocket and also make some payments, which maybe some can't afford at some point. Thank you.
Thank you so much. And Favor, a similar question to you. You spoke about funding within your presentation and how limited funding is having an impact on HPV screening. And so I just wonder, what is it that you're seeing with these new global funding disruptions and the impact on HPV cervical cancer screening and the HPV DNA testing?
Thank you very much for that beautiful question. About the global funding disruptions, I feel like it's actually going to have a toll on the testing because we are trying to push for more people to go for HPV DNA testing. So with the disruption now, there will be a discouragement if they have to pay out of pocket for such tests. Although it has a very high benefit or high sensitivity, and there is a longer follow-up period, they would rather go for what is more cost-effective for them rather than spend more to get the test, especially because they do not exactly understand the benefit. And because of the kind of environment we find ourselves, where so many people believe that nothing is wrong with them until it has aggravated to a very worse stage, then they start running helter skelter. They don't exactly believe in this prevention is better than cure thing only some people do. So they would rather spend more to cure than spend more to prevent. So I believe it is going to be a very huge barrier. And I really do hope that things get better. And the funding is, well, reinstituted because it will go a very long way in people's health. Thank you.
Thank you, Favor. And with your presentation on HPV, I'm reminded that the International Papilloma Conference was just held last week. But Joe, in kind of thinking about how you framed this session and the importance of conferences and being able to attend them and kind of next steps, I'm also wondering, what are you looking forward to when it comes to future STI meetings and conversations?
Thanks, Allison. I mean, there's a lot of great regional conferences that are coming, like within the continent of Africa. There are a lot more African-specific conferences. ICASA is coming up in early December. Within Asia, we have APAC. It's like a regional HIV conference. Um, for people who, for a lot of early career researchers, in some ways, like a regional conference makes a lot of sense for a whole bunch of different reasons. Oftentimes, it's easier to get a visa to go to those countries. It can be a nice stepping stone to then later go to a global conference. So I think, and just in terms of like how things have happened with HIV cuts, a lot of global conferences don't have the number of scholarship slots that they used to. So, thinking carefully about regional conferences, I think is worth considering. And then, in terms of conferences on the horizon, there'll be a implementation science HIV conference in Cape Town in June that's sort of taking Alvin Gung's high IRI approach and adapting it for an African context. I think that'll be exciting, and I don't know if there's already a link, but I'll check and share it with you. Um, and then and then really thinking more carefully about South-South collaboration, that there's you don't really need high income country support for a lot of research, for a lot of programs, and um, thinking about ways that there can be more sharing of experiences and partnerships across different local contexts or LIC, MIC countries. It makes a lot of sense that even though it's difficult to not have the money that was provided by the US government, there will certainly be a silver lining in terms of local jurisdictions becoming more independent, less reliant on external funding. So I think, and the same could be said of conferences, really, that there's going to be less sort of big conferences that offer big scholarships, but thinking about how you could organize something locally is worth considering. Sorry to ramble. Over.
No, it's perfect, Joe. Thank you so much. And I know we are also looking forward to the IUSTI World Meeting in Prague. That will be next year, in October 26th. And then, of course, there is the 2027 STI and HIV World Congress, which will be in New Delhi. So hopefully, we will see some positive changes over the next few months and years, and an increase in scholarship opportunities. But For our presenters and our attendees and anyone watching at AVAC, if you ever have any questions about conferences or how to really engage into some of these conversations or communities, please reach out and let us know how we can support you. And with that, I do just want to thank all of our speakers today for these incredible presentations, and thank you so much for the work that you're doing and your willingness to share these results. The recording of this webinar will be made available shortly, along with PDF copies of slides as well. And if you have any additional questions for our presenters, I do encourage you to reach out to them. So thank you so much to everyone for attending our session today. And with that, this webinar is officially over. And as Joe says in the chat, a big thank you to Progress, our co-moderator today. So I hope you guys have a great rest of your days, and thank you.